Those doctor made my wound bigger. That's a sentence I'm sure people have heard before, and that's more like a patient's perspective, and the evidence may seem undeniable. And yesterday, the patient said the wound was a small hole, but today it looks bigger, and the dressing is bigger, the photograph looks worse, the clinician may have removed some tissue, and suddenly the patient's thinking, the doctor made the wound bigger. But here's the question that I want people to understand. What if the wound wasn't actually made bigger? What happened if the wound was already big and you couldn't really see it? And that's the whole point of understanding wound care because wounds, I don't even know if they're four-dimensional or just three-dimensional, but we're going to understand undermining. So welcome to Diabetic Files. Today we're going to go underneath the wound and talk about undermining. So what is undermining? Because I'm sure patients have heard this before and they're like, why do you have to remove the skin? There's skin there. You know, the wound looks smaller. But undermining occurs when tissue destruction extends underneath intact appearing skin at the wound edge. So think of a cliff. From the top, you may look at the edge and think, oh, that's a boundary, but underneath, there's erosion that has eaten away at the material supporting the edge. Okay, so it's not really any actually supportive skin, and the surface underneath looks like it could be intact, right? But the structure underneath is gone. So that's why it's undermining. Because if you could see, if you put your like an apparatus, let's use a right, underneath in the hole, right? And you just go around the bottom to see if there's any undermining. Like it's like a clock, right? Like a clock hand. If you can go around it, that's most likely undermining. But there's different ways to imagine it, but I want people to understand that the key concept of undermining, it's not a disease itself, right? It's a physical manifestation of tissue destruction occurring beyond the visible wound opening. And in a diabetic foot ulcer, essentially it's telling us that there is damage extending farther beyond what the surface suggests. So imagine, let's say a diabetic foot ulcer that has a 5 millimeter opening at the plantar surface. Underneath the opening, the tissue may be actually breaking down laterally. So the skin at the edge remains intact while the tissue immediately beneath it is lost. So instead of it being skin, wound, bottom, right? You have skin, small opening, and then a hollow space extending underneath the intact skin. And that hollowing is undermining. So basically, the pathophysiology of undermining is usually mechanical stress plus tissue vulnerability that progresses to tissue injury, and that can go to progressing to ischemia or inflammation, will continue to tissue necrosis, loss of supportive tissue, and then separation beneath the wound edge, and that will equal undermining. But in diabetic foot ulcers, every part of that sequence makes it more complicated. So it usually starts with tissue being repeatedly injured. So the classic diabetic foot plantar ulcer is heavily influenced by neuropathy and repetitive mechanical loading. So patient walks, that's why we're telling you to walk on it, and that's why offloading is a big deal. When patient walks on the ulcer, like I said, the foot experiences pressure, shear, friction, and repetitive loading. And normally the pain tells you, oh, stop, something is wrong, right? But the loss of protective sensation, that's why they call it protective sensation, the patient may continue walking. So the tissue experiences the same insult repeatedly, and it creates a cycle. This loading, the tissue stress causes micro damage and inflammation and impaired repair and more loading and progressive tissue destruction. And this will eventually lead to the tissue beginning to fail. So, why doesn't the whole surface completely open immediately? So, because tissue doesn't necessarily break down uniformly, different tissue layers, that's why you need to know that there's different tissue layers, have different mechanical properties and different blood supplies. So, you can therefore have deep tissue destruction underneath relatively intact superficial skin. And this is particularly important in a foot because the pressure can be transmitted through the skin into the subcutaneous tissue. And the deeper tissue may become damaged first or more extensively than you can see externally. And that part of that tiny hole that makes it seem like it's closing can be deceptive. So another thing people need to understand that diabetes makes the tissue quite vulnerable. So we have several processes going on that contributes to the tissue vulnerability in a diabetic patient. Like I said, we have the hyperglycemia that contributes to the advanced glycation end products formation, the oxidative stress, the endothelial dysfunction, the impaired leukocyte function, the altered extracellular matrix biology, and impaired wound repair. And then, like we said, with our neuropathy, the patient cannot adequately perceive the repetitive trauma that's going on. The microvascular dysfunction, so even if you have large blood vessel flow, isn't castro- rheumatically reduced, diabetes can impair your microcirculatory function. And then peripheral arterial disease, when it's present, inadequate arterial perfusion can further the compromise of the oxygen and nutrient delivery. And our impaired immune response, diabetes can impair, as we know, several aspects of the host defense function, so making infection more difficult to control. And then we have impaired collagen biology that happens in diabetic foot ulcers because they have abnormal extracellular matrix cell turnover and impaired progression through the healing progress. So the tissue is being damaged and its ability to repair that damage is often compromised. Then comes the inflammation that is a lot of diabetic foot ulcers are stuck in, right? Because a diabetic foot ulcer isn't just simply a hole, it becomes a biological environment. So after the injury, right, inflammatory cells and signal molecules enter this area. So normally, inflammation should be injury, inflammation, cleanup, proliferation, and remodeling. But with a chronic diabetic foot ulcer, they get stuck in that prolonged inflammatory phase. So there we can have excessive and dysregulated cytokine signaling, protease activity, oxidative stress, and matrix degradation. Okay. And one particularly important concept that we have to understand is the increase in matrix metalloproteinase, so the MMPs, and the altered regulation of tissue inhibitory metalloproteinases, the TIMPs, right? And these enzymes participate in the extracellular matrix degradation, like it's being degraded. And in a healthy wound, that's necessary. But in a chronic wound, there are going to be excessive proteolytic activity that can contribute to the degradation of the extracellular matrix, the growth factors that are needed for repair. And so the wound isn't simply failing to rebuild, it's actually breaking down what needs to be built with, okay? And so also we're going to have a little bit of tissue death, unfortunately, because repetitive mechanical stress plus impaired perfusion, plus inflammation and impaired repair, right? Going to result in portions of non viable tissue. And this can include subcutaneous tissue, fascia, fat, and potentially deeper structures depending on the wound. And as tissue is lost, the skin above can remain temporarily intact. And that's where the wound can become undermining. So, why does the edge become undermined? So, think of a table, and the tabletop is still there, but you've removed the support that's underneath it. So, the tabletop doesn't just disappear yet, it becomes unsupported. And that's essentially what's happening in an undermined wound edge. The tissue underneath the edge has become destroyed and separated. So, the epidermis and dermis may remain relatively intact, but the wound edge extends over the cavity. And that's why undermining is telling us something quite important, that the visible wound parameter does not represent the entire area of the actual tissue injury. Now, another thing is, like I said, infection can make undermining dramatically worse. So, this is one of the reasons why when you see undermining, it deserves attention. So, if there is an infection that's developing in the wound or the surrounding tissue, the inflammation and the enzymatic tissue destruction can accelerate the tissue breakdown. An abscess can create a cavity. And you might have a small opening, track, and then a pocket of tissue. And that's very different from a simple superficial ulcer. And that's why clinicians need to distinguish between ordinary undermining from a deep space infection, sinus tract abscess, or other deeper processes that's going on. Now, why does leaving undermining alone problematic? And I hope patients can understand this. Undermining itself isn't automatically mean that you have to cut it out, but I remove undermining tissue. I do. Okay. When I see it, I remove it. Okay. But clinicians need to determine, and that's based on also vascular status, right? Clinicians need to determine what the tissue is actually telling us, right? Is this tissue viable? Is it necrotic? Is it infected? Is it callous? Is it there viable skin flap? Is the tissue covering a dead space? That's something I often see with undermining too. Is the tissue associated with an abscess? Okay, so remember when you see undermining, I think undermining is very deceptive. Okay, and it's deceiving the patient as well. So we have to assess if this is non-viable or if this is infected tissue. Is if it's present, we have to do appropriate debridement when indicated. Okay, because leaving it behind can definitely interfere with the wound management. I've seen patients with undermining skin that they have had it for weeks and consistently dressing it appropriately. But I'm telling the truth. I tell the patients the truth. This wound is not going to close unless we remove this undermining tissue. That's the truth. Now, like I said, undermining can also hide a dead space, like a cavity underneath it. And this depends on the clinical circumstances of the patient's wound. But dead space can create an environment where fluid accumulates, exudate accumulates, where bacteria can persist, where tissue surface remains separated, and healing tissue cannot adequately bridge that space. Now, another thing is, like I said, wounds give us clues. Undermining is a clue. When you see undermining, don't just think, oh, there's a hole underneath the edge, right? You should think, why did the tissue underneath disappear? That's a clinical question because undermining may be telling you that about the wound mechanism. It's if it's a plantar diabetic foot neuropathic ulcer, think, pressure, shear force, neuropathy, and repetitive trauma. But if there's significant ischemia, we have to think if there's inadequate perfusion, that means that there's tissue failure, and that means that that will result in poor healing. If there's infection, that means that this is inflammatory destruction, if there's an abscess or deeper infection. And, like I said, pressure injury, shear forces causes more. And if this is post-operative, you got to think of wound adhesions, dead space, infection, tissue viability, and mechanical tension. Okay, because the geometry of the wound can therefore provide a clue of what's happening biologically. Now, like I said, undermining tells us that the wound is actually three-dimensional. So wound isn't just length and width. Remember, wound is length, width, and depth, and as well configuration. Okay, so that's why I said it kind of is four-dimensional. But maybe I'm wrong. Physics people out there, if I'm wrong, I'm wrong. Sorry. And configuration includes tunneling, undermining, cavities, sinus tracts, and tissue involvement. So if someone says it's only 1 centimeter, your response should essentially be 1 centimeter in which dimension? Because 1 centimeter opening can potentially communicate much bigger things that's going on. So why does this matter for us when it comes to limb salvage and diabetic foot file? Undermining is usually a warning sign that the wound is more extensive than what it looks. And I know when we try to play the patient and make them understand undermining, and then we have to remove it, and they're like, if the wound is bigger now, look, you made the wound bigger. No, I made the wound better. The wound is going to be so much better now, okay? Because that like I said, undermining is deceptive. People underestimate undermining, okay? When you do that, you're underestimating the depth, the infection, the pressure, the ischemia, the tissue viability, and thinking that it's just a hole, okay? But no, the doctor did not make the wound bigger. Actually, the doctor made the wound more visible, okay? And we have better visualization of the wound bed. So yes, the wound looks bigger, but yes, we could have more visibility of the wound and more of the wound bed and knowing how to treat it appropriately and that it won't have to hide infection from us, okay? And you know what? I don't want to imply that, bigger the debridement means better, but I have learned from my experience after assessment of vascular status, knowing that it's appropriate to debride, that it looks better afterwards. After we remove the undermining, that's what happens, okay? But, when undermining is identified, we have to investigate and figure out and assess the underlying causes. Is it because of perfusion? Is the perfusion adequate? Is it because of infection? Is it because of mechanical stress? Is it because of tissue viability? Is it because of depth? Is it because of tunneling? Is it because of exposed structures? Is it because of systematic factors like nutrition, renal disease, smoking, other things? Okay. But the best takeaway we can have from this, undermining is the wound telling us that what you see on the surface is not the whole story. But the question should be, isn't why did the doctor make my wound bigger? It's about what's happening underneath the wound that I couldn't see. And that's the whole purpose of things like this, like diabetic foot files, and making patients understand and people understand why it's so important for us to assess the whole entirety of the wound and why undermining can be giving this false reassurance that the wound is closing for the patient because it's not, okay? Because the wound can be smaller, but can actually be worse underneath if you have undermining. So, what are things that we can do to prevent undermining? Preventing repetitive pressure. That's why offloading is key. Inspect diabetic feet appropriately. Treat calluses appropriately. Control edema. Address vascular disease. Treat infection promptly. Avoid unnecessary trauma. Protect fragile skin. Optimize diabetic management. Stop smoking when applicable. I mean, my patients already know you shouldn't be smoking. Maintain adequate nutrition, and follow wound care instructions, okay? Don't wait for a tiny wound to become bigger. And yes, undermining can become a paradox, but and it'll be like, oh, the doctor made the wound bigger and it looks worse. But I promise you, the right clinician knows what to do with undermining, and you just have to trust. Trust that the doctor is doing the right thing, and you will know by next week. You would know by, the next follow-up. Usually, like I said, the body wants to close the wound. If we remove all the blocks that are keeping the wound open, it usually closes beautifully, in my opinion. That's what I've seen. But also another thing is undermining is just not just a measurement, but remember you have to do it. They measure it by like a clock. They'll be like undermining from 2 o'clock to 6 o'clock, things like that. That's another thing to keep in mind. But like I said, undermining is kinda like an iceberg too. And remember, they tried to warn them in the Titanic with the iceberg, and they didn't listen, right? They didn't listen to the warning sign. Titanic historians, sorry if I got that exactly wrong, but I just know that they were warned about the iceberg. Okay? But long story short, if you think the doctor made your wound bigger, usually it's not. The doctor made the wound more visible. Most likely there was undermining or a dead space. We have to remove that so that the wound can actually heal. These things are blocks. So we have to remember that, there's more things that are going on. Wounds are usually three-dimensional as well as maybe four-dimensional. But what we're trying to do when we're removing the undermining tissue is we're trying to give the tissue the best possible chance to survive and heal. Okay? So don't ever confuse a smaller opening with a smaller problem. Wounds can hide, they can tunnel, they can undermine, they can extend underneath intact skin. And sometimes the first step in healing isn't about making the wound look more modest and smaller, right? It's about if the wound is bigger underneath, let's just figure it out, expose it, make the wound bed bigger, make the wound bed more visual, forgive me, and let's remove all the non-viable tissue. Okay? So this is diabetic profiles. I hope everybody can understand that, understanding undermining is not a diagnosis, but it's quite helpful. And, you know, I don't want patients to understand that things get bigger before they heal, but sometimes it does, okay? And like I said, I've said in a previous episode that I usually feel like I'm on probation period with a patient when it comes to debridement because they hate seeing a scalpel. But once they realize that debridement helped and it made the wounds smaller, then the patients are like, my patients are like, yeah, they truly understand. They're excited because you know what? It's like magic. It's like magic when you remove all the blocks on a wound, especially a diabetic foot ulcer. So this has been Diabetic Profiles. I'm Dr. G, and take care of your feet because they take care of you.